Okay, back with us today is Dr. Nick Birch. Nick is a consultant spinal and bone health specialist, a fellow of the British Orthopedic Association, and a member of the Royal Osteoporosis Society. Nick has been widely published in the area of orthopedics. He has been involved in 35 peer-reviewed papers. And for the last 28 years, Nick has run a busy spinal and bone health practice in the UK. Now, Nick is also a pioneer of a new and validated bone assessment measure called REMS, which is now available in Australia. In part one, we covered all the bone-related information, how your bone is constantly changing, what is DEXA, what is REMS, and the novel new marker called the Fragility Index, which I am lately just so obsessed with. Now, in part two, we're going to use me as a case study and look at both my DEXA and my REMS report to see what we can learn. Nick, thank you so much for coming back to teach us all more about bones.
Thanks very much for inviting me again. It's lovely to be with you.
Now, when researching for this episode, I go to great lengths in my research. And so I did my DEXA, I did my REM scan, and both assessment methods confirmed osteopenia in my spine and hips, which I was really surprised at. I'm a very active person. But one marker that did help put this in perspective for me was the Fragility Index. So it shows that for me, my bone microarchitecture looks pretty good despite the osteopenia. So Nick, I'm going to hand it across to you. Can you talk us through my scan so that we can all learn a lot more about REMS and DEXA and how important these are?
So this is your first DEXA that you had back in March 2023, so 2 years ago. Now, for you and anybody looking at a DEXA scan, the first thing is to say, how do you actually interpret them? And what do all the various bits mean? We went over in part one some of the measures that DEXA produces, which is the T-score, which is comparing you to a young, healthy adult, roughly a 30-year-old woman. We didn't mention the Z-score. So the Z-score is comparing you to other women your age. And that's really important because particularly post-menopause, you need to know, are you right for your age or not? So that's the Z-score. And then you have something called BMD, which is bone mineral density. So when you look at your bone mineral density, that's the actual amount of bone within the measured parts of you. That's the hips and the spine. So all of those things are exactly the same on REMS and DEXA. That's fine. What's the difference? We'll go on to the fragility score. But let's start off with the first question. Have they put into the report the correct demographics? So first is your name Emma Sutherland? Or is it Emma Sunderland? Or could it be something different? So check your name. Are you female? Okay, so there are some issues regarding that, and we need to be aware of those. So risk factors fall, FH, family history is what that stands for. Okay, so that means you've had a fall. You may or may not have had a fracture. It doesn't say that there's a fracture there, but you've had a fall and there's a family history. Next thing is height. Are you actually 153.5 centimeters tall, which is just over 5 foot in the old coinage? And are you 55 kilograms in weight? And is your date of birth correct? Which is, I think that Australian, you use the same formats we do. That's the 8th of December. Yeah, that's fine. 8th December 1973. So that makes you 49. Okay, so you've checked all the demographics. Now, I see hundreds of DEXA scans every year, and a few come up with there's sort of some slightly odd statements. I don't see that they have put in your ethnicity.
Right.
So the question then in Australia, are all ethnicities the same? And I suspect not. In most densitometry analyses, you have 4 ethnicities. You have white, black, Asian, and Hispanic. And that's a problem because Asian covers anywhere from the tip of Sri Lanka in the south to Mongolia in the north, as far east as Japan, as far west as Iran. It's a very, very big area. And then within that, there's a whole bunch of ethnicities. So the question really is, are you looking at like for like? So if there is an ethnicity statement there, make sure the ethnicity is actually correct. So then the first thing to do, that's a sense check. So the sense check in my world is called the Osteoporosis Self-Assessment Tool. The Osteoporosis Self-Assessment Tool was developed in the Philippines in the 1990s. And that was at a time when the population of the Philippines was 78 million, spread over many, many islands. And so one big island and then lots of little ones. And there were only 4 DEXA machines in the whole of the country. So it
Well,
meant that active DEXA was very, very limited. So they needed something that if you had a woman on an island who needed to travel to the mainland to get a DEXA, and what they came up with was that the application of Wolff's law. Now, Wolff's law is the law of physics that says the more you load bone, the denser it becomes, and the less you load it, the less dense it is. So therefore, the heavier you are, then the more dense your bones will be. But it changes with age as well. So they determined that if you could look at just weight, i.e., someone could go to the island with a set of scales, they could measure weight, as long as they knew a woman's age, they could figure out whether she was likely to be osteoporotic or not. There's what's called a cutoff. Below that cutoff, then you're going to be osteoporotic. Above that cutoff, you won't. You'll be osteopenic or normal. Originally, for the osteoporosis self-assessment tool, the cutoff was -2, roughly. Below -2, you're pretty much likely to be osteoporotic. Above -2, there's a zone in which you might not be, but really sort of much above +1, +2, you're not going to be. So let's do the osteoporosis self-assessment tool for you. So you weigh 55 kilograms. Your age when you had this first scan was 49 years. Therefore, the difference between the two is +6. And what we have to do is take 1/6 of that. And that gives you a score of 1.2, which is well into the positive range. Therefore, you could not have osteoporosis. And indeed, your scan shows below the lumbar spine T-score -1.4, osteopenia. It's not osteoporosis. However, you have got remarkably dense hips. So here, dual femur, neck of femur, young adult T-score, 0. So that means that you have bone density, which is well above average for your age in your hips. How's that come about? Just hold that thought. The second thing is that if you look at all these numbers here, apart from the dual femur total right, this 0.6 here is, if you take that from the spine T-score, the difference is 0.8. That's okay. You're allowed to have a difference between your 2 T-scores, between the hip and the spine, of 1.0 or less. That's okay. But if you look at this one here, neck of femur on the left, 0, that is 1.4 different from your spine. Now that's called discordant. The discordant figure is one where you don't have the T-scores that are close enough to make physiological sense. So the first thing here, we've got a bit of a discordance with your T-scores. We know that you've got 2 different diagnoses. The first diagnosis, spine, is osteopenia. Second diagnosis is that the hips are normal. So 2 different diagnoses equals diagnostic discordance, and you've also got a numerical discordance. You have got, according to all this, absolutely fabulous hips. You know, these are the hips of a 30-year-old because it's 0, because it's the same as a 30-year-old. Whereas you've got a T-score of your spine, -1.4, so that's much reduced, but not osteoporotic. First DEXA may be an issue. Right. So let's go then to the way that the DEXA has been done. So here is the picture of your spine. The first thing you notice is that you've got a little curvature on your spine. And it is well known that DEXA does struggle with getting accurate measurements if you have a curvature on the spine. Now, it's not a big curvature, it's a little curvature. So maybe something that might be producing some inaccuracy. We're not sure, but maybe not. Maybe 1.4 is about right for you. Can you see down here, down the bottom, you've got darkness in the bone there?
yes.
That suggests your disc between L4 and L5 might be a bit degenerate. Did you get back pain?
I've got spondylolithiasis, so that's compressed.
Okay, that's picking up that you actually do have some degeneration there, and that's spondylolisthesis, therefore it's likely to be hidden in there. So the next thing we're going to do is just to look at the progression of your bone density. So BMD, bone mineral density, in L1 should be the least, because going back to Wolff's law, there's at least weight going through L1, more through L2, more through L3, most through L4. So you should have the lowest bone density at L1 should go higher, higher, highest, just about. Okay, so your progression of bone density is pretty much okay. That's absolutely fine.
Okay.
And I think then the overall average that -1.4. So looking at your spine score makes some sense. That's okay, fine. Okay, question. Are you postmenopausal?
No, still not.
So premenopausal, but you're slight. So 55 kilograms and 155. So body mass index is in the region of about 23. You're not a big person, normal sized person, but sort of tending towards the slight side of things, which is fine. So that fits in quite nicely. This is called the trabecular bone score. This is looking at the spinal DEXA, and it looks at the textual grayscale analysis, and it tells you how tough your bone is in the spine. And there's a very easy way to figure out how the TBS works. 12 to 10 plus 1. That is, if it's below 1230, i.e. 1,250, so 1,230, you have low or significantly degraded bone quality. If it's after 10 past 1, i.e. 1310, if it's above 1310, then you have normal bone quality. And between the two, it is slightly degraded. So 12 and 10 past 1 are the ways to remember how to interpret your TBS.
Okay.
So yours is fabulous. So here we are, 1.39, 1.42. You've got fabulous bone quality, which is great. Now, then we look at your hips. And can we look at these and say, okay, how well has this been done? When you look at the X-ray itself, do you see all these boxes on here?
Yeah.
These boxes are called regions of interest. And what they are is telling the computer which bits of the bone and which bits of the soft tissue next to it to analyze, to be able to tell you what your bone density is.
Okay.
Now, the only thing that I can see on here that is slightly not quite right is that box there, which is the neck of femur box. First of all, do you see how it clips this bit of bone here?
Yeah.
It's included. It should not include that.
Okay.
It also just about clips this bit of bone here, and it shouldn't include it. You've also got that little bump there. That's the lesser trochanter, which is the bit of bone, that the big psoas muscle, that big flexor muscle in front of your spine that attaches to. So there is a suggestion here that maybe this is then over-reading your bone density. This might be why your hip bone density is reading as being amazingly good.
You just burst my bubble.
It could be that you are an amazingly good person, that your hips are fantastically better. However, when we look at the right hip, exactly the same. So it's picked up a bit of this bone here, which you shouldn't do, less of this. Okay.
Got it.
Now, if we go to the neck of femur 0 on your left side, i.e. the hip of a 30-year-old, and then minus 0.1, virtually the same, hip of a 30-year-old. So question then is this reasonable? Look at your Z score, 0.8. That says you're 8% above average for your age. Now, when you want to sense check to think about your age, if you think about the relationship between bone density and body mass index, they pretty much match each other. They move the same direction. So BMI goes up, bone density goes up. BMI goes down, bone density goes down. And if you have an average bone density, you should pretty much have an average BMI as well, because it's population based.
Okay.
So average BMI for women in Australia, if it's anything like women in England, it could be about 27.8, 28 for women your age. So that means that if you have a positive Z score, you're 8% above average, which means you should have a BMI around about maybe 29. But you don't. Yours is 23 or thereabouts.
Yeah.
So this doesn't quite make sense. So it kind of makes you think, okay, maybe these errors are overstating your bone density, and maybe you're not quite as wonderful as you thought you were. Okay, so that's the DEXA scan. And then if we change to your March 2025 DEXA scan, very similar. Okay, so you're premenopausal, that's fine. You shouldn't be changing, certainly not going downhill at a very rapid rate. Minus 1.3, 0.1, et cetera. So the numbers are not very different. Here now, you begin to see that dark area in your X-ray, which is your spondylolisthesis. That's now being picked up a bit on that L4 box. So this region of interest here is looking at your L4 vertebra and the soft tissue next to it. Do you see how it's that box has picked up a bit of the pelvis here?
I do.
Okay, so maybe there are some errors there. Who knows? Maybe that's why it's slightly better 2 years on, whereas it might be expected to be maybe 1% different, maybe a little bit lower. Go to the spine. Your TBS, again, fabulous. That's fine. However, note of caution, your TBS is only as good as the X-ray that's been done for the DEXA. So if the DEXA X-ray has been done slightly inaccurately. Your TBS might be slightly inaccurate. However, we knew from your previous TBS that it should be in this region. And when we know that you are a fit, healthy person putting lots of impact exercise through your spine, so we know that the TBS is almost certainly a very good reflection of your true bone toughness in the spine. So going to your hips, again, our femoral neck blocks here, just touching the trochanter there, the greater trochanter, just touch the bone here. Maybe not, slight error. That lesser trochanter now, you can see it's been turned. So therefore, the rotation of your leg where you are having the DEXA scan is slightly better. So this is a slightly better positioning than it was in the first one. But the numbers are still much the same. So why is that? We don't know. Okay. On this side, really quite interesting. You see here, you should not have that box encroaching that far into that bone. That's really quite wrong. And now you see here, look at where you are, 0.1 neck of femur, left side, and suddenly your right side's 0.3, but it was minus 0.1 2 years previously. Why is that? Because you've suddenly been doing a whole lot more impact exercise on your right side? Probably not, but maybe that there, because actually there's an error on that neck of femur box. So that's how you read your DEXA scans. Okay, so you're looking to see what is accurate. You're looking to see what the diagnosis is. Diagnosis, osteopenia, normal. Does it sense check with your osteoporotic self-assessment tool? Does it sense check with your Z-score? Let's go back to the OST, osteoporotic self-assessment tool. You put a bit of weight on. You put some muscle on. Between 2023 and 2025, you put muscle on. So now you're 4 kilograms heavier, 2 years older. Difference between the two is 8. Take a fifth of that and we get 1.6. So you're slightly further away from osteoporosis, which is exactly what the test is saying. So use the OST as a sense check. Is it positive? Yes, it is. Are my results out of the osteoporotic range? Yes, they are. It's a binary thing, but it's a good sense check. And I see so many women who have discordant results. So they'll have a T-score in the spine of minus 3.5 and a T-score in the hips of minus 1. Hang on a second. The two can't be right. Let's sense check them. And the OST is quite useful for that.
Yeah, fascinating. Okay. What I do find interesting is that the hips are falsely elevated because they've included bone that isn't from the hips. I mean, that sounds so basic, but I hadn't picked that up myself, and I've looked at these 100 times. And I look at patients all the time. And this lab at St. Vincent's is one of the best in Sydney because they're about the only ones that do the TBS score. So it has been historically where I refer my patients to. But it goes to show that even at a really good clinic, they're making these technical errors which are changing the results.
Yeah, and actually looking at the two associate professors heading there, Nick Pocock is one of the most well-known Australian, I think he's an endocrinologist, but he's very well-known as running a really, really good bone density unit. But you know what? Looking at this, I think there are potential errors, and this is maybe not being picked up. So anyway, let's go on. Let's start now with REMS. So REMS looks completely different. The first thing about REMS is, and anybody watching this podcast, do not look at that picture of a femur and think that's an X-ray. It is not an X-ray. It is merely a graphic that's there to demonstrate the bit of anatomy you're looking at. And the gold band around the neck of the femur, that's not how the bone really looks. It doesn't look like that. Okay, this is just graphics. That's the first thing. So do the same again. Are you Emma Sutherland? Yes. Was it done on the 3rd of October 2024? Is your date of birth 8th of the 12th, 73, etc. Going through that. So when you had your REM scan done, you were 50 and your weight was 57. So you were transitioning between your 55 kilograms in 2023 and your 59 kilograms now. But this gives you an OST of 1.4. The difference is 7. So it's a 1.4 OST, well above 0, well, therefore, away from the cutoff from osteoporosis. So you shouldn't have osteoporosis, and you don't have. And what REMS has told you is that you've got a T-score of -2, and you've got a Z-score of -1.2. So the Z-score now for your spine is negative. It should be negative because if we are saying that Z-score 0, which is average, should reflect someone who's got average body mass index there or thereabouts. Because you're below average, you should therefore have a negative Z-score. So you got that, which is good news. You've also got the same as the DEXA output. You have the trochanter and the total. In fact, I think that the DEXA output only had total and neck, whereas the REMS does actually have the trochanter. This is the trochanter, this bit on the outside here. That's the greater trochanter. And then the bit we saw on that first DEXA of yours is the lesser trochanter, the little bobble of bone. So this is therefore looking at you saying, okay, well, you're osteopenic. That's exactly what you're supposed to be according to the osteoporosis self-assessment tool. And your Z score is negative as it should be. Let's go on to your right hip and minus 1.9. Very, very similar. Okay, so minus 2, minus 1.9. But look at BMD, bone mineral density, to see exactly how far apart they are. So this is 0.636. And that's 0.627, so only 0.009 grams per centimeter squared different. So you are slightly right-sided dominant. Are you right-handed?
I certainly am.
Okay, so you're putting a bit more weight through your right side, and that's giving you a slightly higher bone density. So that's fine. So we therefore have two hip scores, which are very, very similar. Your spine score, remarkably, that's also very similar. So there's no discordance. So now you have osteopenia, all three sides, and your T-scores are very close to each other. So minus 2, minus 2, minus 1.9. So there's no numerical discordance, which there was with the DEXA on both occasions. There's no diagnostic discordance because it's all the same diagnosis. So when we start thinking about quality control and bone densitometry, the first rule of densitometry is that your T-scores, as I said earlier, they should all be within 1.0 or less. And yours are maximum difference here is 0.1. So there's no discordance here. The second thing to look at is because you've got individually 4 bones in your spine, you should then have similar T-scores going down. 2.1, 2.1, 2.0, 1.8. You do. And the gap between individual vertebrae should be 1.0 or less. So nothing there, 0.1, 0.2. So that's the second rule of densitometry is therefore fulfilled by this scan. And the third, as we said, when we looked at the DEXA, is that you should have the lowest bone density Del1, BMD, bone mineral density, 0.68, 80, 86, 91. So you have a nice cascade of increasing bone density going down. So this REM scan, therefore, fulfills all 3 of the rules of densitometry that are laid down by the International Society for Clinical Densitometry. And they laid those rules down years ago. And therefore, you can take this as being an accurate REM scan, and it can be compared to any other scan anywhere in the world done by any technique that obeys the same 3 rules of densitometry. If the rules of densitometry are not obeyed, the scan cannot be then compared to them. And that means we can't compare your DEXA scans to this REM scan because the 2 DEXA scans have got discordances. So therefore, you can look at these and say, okay, fine, they're 2 different technologies. They're measuring you different ways. How do you know whether this is really true? Well, first of all, the rules of densitometry. The second is repeat the REM scan in a year. So do it again in a year and maybe have somebody else do it. Maybe not David Togherini, maybe one of David's colleagues, his colleague in Sydney, does it again. And if the numbers coming up are exactly the same and the settings of the machine are exactly the same, you can be pretty happy that what you've got is a true reflection of your bone health. And then what you're looking at is your trend line. You're not really thinking about single points. You think, am I changing over time? Does that fit in with my post-menopausal status? Okay. So going on from there, the next thing is the important bit from your point of view, because you have so focused on it quite correctly. And that is your fragility score. So this is the fragility score result. The fragility score is an indicator of bone structure. It's independent of bone mineral density, so it's not looking at the same thing at all. And what it's looking at then is, are you close to people who have never fractured, or are you close to people who have fractured? Fragility goes from 0, i.e. no fragility, unbreakable bone. Nobody has that. Well, there's only one person in history who's ever had that. Do you know who it was?
No idea.
It was Wolverine from X-Men, because he had his bones and he had adamantine replaced, and so therefore he could never break a bone. However, 10 is the lowest that we see clinically. And then as you go up the scale, then you get to 100, which is bone so fragile that if you stand, you break. Nobody has that. 95 is the highest anybody's ever recorded. 92 is the highest I've ever recorded. So you are pretty close to the best you could be 4.3 points away from the very best you could be in your left hip. 14.3 is phenomenally good bone toughness.
Right.
In your right hip, you're 14.1, a difference of only 0.2. That is maybe as we'd expect, but your 14.1 is slightly better than your 14.3, which again shows that you are slightly right-sided dominant. So that fits in with what you know about yourself and your exercising. In your spine, a woman your age, I expect your fragility score to be 8 to 10 points higher. There we are, 24.3, you're 10 points higher. And the reason for that is because the structure is different. The spine structure is a very much a honeycomb bone with a very thin shell of the bone around it. And the hip's exactly the opposite, pretty much. I mean, that is what? Much more dense cortical bone, which is the outer bone, and then less of the honeycomb bone inside. So therefore, you get a difference between the two. And that makes complete sense. And then if we go on from that, what we can do, importantly, is put the two together. And this is therefore the combined matrix of bone density, i.e. your T-score, and bone toughness, which is your fragility score. And we know you have osteopenia and normal toughness, and that gives you a risk level of 3. I'll go down to the table, and for the hip, your R3 level is 4 to 8 chances out of 1,000. Look at that number there, 0 over 0.00. It's not percent, it's per mila, which is per 1,000.
Yeah.
Okay? And this is therefore, translate into percent, is 0.4 to 0.8% chance of fracturing your hip in the next 5 years, which is low, very low. That's fine. You don't need any treatment or any consideration with that. Your right hip will be exactly the same. There we are, 0.4 to 0.8. And your spine will be 1 to 2%. It'll be 10 to 20. Again, your R3, 10 to 20, 1 to 2% chance of a spine, an upper limb, or another lower limb. So these are major osteoporotic fractures. So that then is your overall risk. So you've got osteopenia throughout. You've got no discordances diagnostically. You've got no discordances numerically. You've got a low risk of fracture over the next 5 years in your hip, a low risk of fracture for major osteoporotic fractures, spine, upper, lower limb, etc. So you're in great shape in terms of your bone quality, your bone density, your bone health. Yeah. So the first thing is we look here and say your body mass index, I said 23, it's 24. That's fine. It was 23 in 2023. Total body weight, 57. This is your ideal body weight for your age and your height. So slightly above that, which is fine, but that's muscle, and you put the muscle on. And then this is telling you what your body fat composition is, and that's mostly visceral fat, a little bit subcutaneous, 0.1% above the normal range for your age. This is like slightly fat shaming you, but it's not fair.
No, it's okay, Nick, because to be honest with you, this is the classic perimenopause, which I see in my patients too, is that we put on a little bit of weight in this hormonal transitional time.
Correct.
So that completely makes sense to me. And I definitely have put on muscle as well because I've been working hard to improve the bone mineral density side of things. So I think it's a bit of both.
Yeah, don't reach for the Ozempic.
No.
Then finally, you might wonder what these are. This is the actual image on the ultrasound screen that you see when you're doing the scan. And what you've got here is that dark thing there is the aorta in front of your vertebra. And you should see, this is the L1 vertebra here, that sort of bright signal is the front of the bone. And that's got to be nicely in the middle of this picture, underneath the red line. That's fine. And then you see the same for L2, for L3 and L4. So you can look at these and you can look at the spine, the hip as well. So the hip here, you can see there the rounded part of the ball and socket. And here's the neck of the femur, nicely in the middle, underneath the red line. So this is a way to make sure that your scans have been done properly, and they have been done properly, which is what you'd expect. Your DEXA scans, even though they've been done St. Vincent's, no, I totally accept that Nick Pocock's got a fantastic unit there, but I've identified that there are potential errors in those two DEXA scans, and that maybe needs to be addressed. The REMS scan, all of the quality criteria that I can see are met, and I think you can therefore take it as being okay. This is reflective of your DEXA spine, not reflective of your DEXA hip. Maybe there's some issues there, who knows? But what you can say, what I can say is that if this is your first REM scan, what I would do is to have another REM scan a year after that. Make sure that the two are very, very similar. and then have your next scan once you've got confirmed menopause, which is 12 months after your last period.
Yeah. And I think for me as a patient in this case, and looking at all of this information, what I found with the REMS is that it was much more easier to understand the reporting. So that was great. And also, it's a lot easier to do a REMS scan than it is a DEXA. The REMS scan, it just was like, for anyone that's had an ultrasound, it was just like having an ultrasound. It was very non-invasive. It was very quick, very efficient. And I felt it was just a lot easier process. The other thing to know here in Australia is that you don't need to have a GP referral to get a REMS, whereas with DEXA, you need a GP referral. So there's also one more kind of barrier in the way from a DEXA versus REMS perspective. But I'm already super excited to redo mine in October this year and to see the similarities, the differences. And I love how the REMS, the concordance and the values are far more accurate, essentially, overall. And that fragility index is just so reassuring to know that even if I have osteopenia technically, my bones are tough and strong, and I just need to keep doing what I'm doing and keep them that way.
I think the term that I use to explain to all of it is that if your bone density is appropriate for you, i.e. your lifestyle, your height, your weight, etc., your age, if it's appropriate for you, we can look at that, look at the Z-score, look at the osteoporosis self-assessment tool. After that, your bone density doesn't matter. It's appropriate for you. It's going to be what it is. Then it comes down to the fragility score. Add that into the mix. But you're not just your T-score. You're not just your fragility score. You're everything. You are your physical self, your mental self, your nutrition, as we said on part 1. You get all of those together, your exercise. If all of that's working together, then you have good bone health, good muscle health, and a general physical health, and then good mental health. One of the problems we have is that with primary prevention of osteoporotic fractures is this use of DEXA as a screening tool that gives you a number that then determines a treatment.
Yes.
That doesn't look at you. That's algorithmic medicine. That's not actually saying, hang on a second, you're a certain age, you're a certain weight, you're a certain height, etc. You've got a certain pattern of exercise and diet and all this stuff. Let's look at the whole thing. No, you had a DEXA scan. It said minus 2.6. That's it. You're on 5 years of andronic acid. I think medicine's kind of lost its way when that is the default of how we're going to treat women. Then save a few women from a fragility fracture, but you've got to treat an awful lot to do that.
Really?
And how many women are going to be really unhappy because they have side effects? And how many are going to be scared? It's a real problem.
Yeah, I would agree with you. And that individualized approach to medicine is what, as a naturopath, it's our core philosophy that we're individualizing our treatment approaches to our patients rather than giving generic, just blatant, this is what we all do, because it's not the way that it works.
No.
Yeah, I think that framework that you've outlined is absolutely fantastic. Nick, thank you so much for going through everything with us, part 1, part 2. If people want to find out more about you, where can they find you?
Osteoscanuk.com.
So for anyone that is in the UK that has not yet done a REMS scan, go and see Nick. I will list in Sydney where you can get your REMS scan done. I'll list in Melbourne as well so that we can have this as accessible as possible to as many people as possible is my goal with this. So thank you for being such a pioneering spirit in this world of bone health, Nick.
You're very welcome. And thanks very much for inviting me. It's been great fun.
Thank you so much. We'll see you again soon. Thanks so much for being with me today. Don't forget to like this video and hit the subscribe button below. Check out the links in the show notes for more health empowering information and ask me any questions in the comments below.